basis, it's the strongest vasoconstrictor, most powerful vasoconstrictor that we have. And the doses that we use at UK are minuscule doses to other units. And the way to think about that, if you're running a coda, you're going to give vasopressin. How much do you give? 4 units, yeah. And how much do we give to our patients post-op? The most is like 0.04 or something like that units, which ends up being like 2 units or 2.5 units an hour. It's like nothing. And in Millinol, we spoke of that. So let's say we come out of surgery and you got one of our patients who's been in there for a while, and they come on, they come out on a concoction, and that's where it starts getting interesting as far as trying to figure out how to do it and what to do. I found some right here. Perfect. All right, the typical concoction would be, the patient's in the operating room, they're trying to come off pump, they can't come off pump. So the first thing that gets added here is epinephrine. Okay, the epinephrine gets added, and it gets added at like this dose, 105 microkill per minute, and then you start giving protamine and things start going bad, and so it gets raised to 0.1, and then they come out at 0.15, and if they're on that, suddenly their blood pressure's low and their cardiac output's low, so they get started on levofed and vasopressin. And then they got such fact their vascular resistance goes up, so their cardiac output goes down, and so then they get started on milrinone. And then, although they're still looks like they're in a coma, we better put them on something so they don't hurt and don't respond. So they get started on Presidex, which is I don't know, y'all have a different name for it. Presidex is dexamethasone. Yeah. They start on Presidex. Oh yeah, and by the way, since they got a mammary, somebody puts them on nitroglycerin too. But this is like 0.1 something, but it's there just because the mammary's not going to spasm of that, which is nonsense because they're on all this other crap. That's not going to do anything for them, but it's on. And so they say, okay, see y'all, take care of them. Right? Yeah. And then you got the critical care intern there who's never seen a heart patient. And you're trying to figure out what to do. So it looks like it's really complicated, and it is, but it's not that complicated. If you know what the drugs do, it's really not that complicated. You say, okay, let's break it down. Epinephrine, 0.5, low dose. That's going to be beta. That means it's going to be cardiac output. Good. High dose. We're still going to have some beta, but now we're talking about alpha. Not good, because of peripheral constriction. Levofed, alpha. Vasopressin, alpha. This is the most powerful one. Milrinone, cardiac output and decrease peripheral vascular resistance. Presidex, basically it's putting them to sleep. Your blood pressure goes down when you sleep because you're not generating your own intrinsic catechols. So Presidex is a downer for cardiac output and blood pressure. And the nitroglycerin is not doing anything because it's at such a dose that we really don't have to worry about it. We can turn it off if we want to. We probably should. So what are you going to start weaning first? Any takers? Depends on what the hemodynamics look like, right? Right. So if you got this patient who comes out and their mean arterial pressure, say their mean arterial pressure is 55. It's low. And you look at this cardiac output, and the cardiac index, very simply. The cardiac index is 1.5. What drips are you going to wean? None. patient's hosed. They need more, if they're not in tamponade, they're in trouble, right? Because you don't have enough cardiac output and you don't have enough blood pressure. So this patient, all right, this patient is going to need some rocket fuel, something to get them going. So if you, in the reflex response to this, is to focus on this being arterial pressure. That's the reflex response. We got to get the blood pressure up. So we're going to go here to vasopressin and crank it up, or leave it there. What's going to happen if you do that? Yeah, this is going to go down even further. So you have to have a leap of faith and say, the reason that this is down and this is down is because we don't have enough contractility. Or pulmonary capillary wedge pressure, PA pressure is low. If PA pressure is low, then we want to get that Starling curve, fill them up a little bit, and move up the curve to see if we get up here. Typically in these patients, however, it's not low when they come out of the operating room. It's high because they've been flooded with everything and they're all swollen. So the only thing we can do for this patient is either provide some type of mechanical support, a balloon pump, or something, or some kind of assist device, or try to go up on milrinone on something that's going to try to hit this in a different area, not on that catecholamines, because we've got all sorts of catecholamines going, but phosphodiesterase inhibitor to try to get things going elsewhere. When we do that, we know that's going to be a vasodilator, but we're already on all the vasoconstrictors we can have. We need to have some cardiac output. And if you got a lot of cardiac output, you get your cardiac output up, it's going to get your blood pressure. Okay. That make sense? Now, let's take the same thing. We got a cardiac index of 3. Now what do we do? Okay, so say, man, that's crazy. I don't have any blood pressure. He's got a cardiac index of 3. What's wrong? His vascular resistance is going to be really low. So the blood's getting pumped into like a swimming pool, and you can't feel the pressure. So then you look at the drugs and you say, okay, which one of these drugs are vasodilators? If they're on milrinone, you decrease the milrinone because you know that contractility and vasodilatation. If they're not on some drug that it can give them peripheral vascular resistance, that's when it's very appropriate to start one of these drugs that I hate because of the peripheral vasoconstriction, levodopa or vasopressin, to give them some resistance. Or make sure you check their hematocrit, because if their hematocrit's low, there's water going through their veins as opposed to blood, which has some viscosity to it. And it's amazing how often that will be the case. Because you come out and they told you their hematocrit was 30 and you check it and it looks like water coming out of the heart line. You say, well, what's wrong here? So all these have to be manipulated in what you see. When you're doing this, the first 6 hours is like a rodeo. If they're not bleeding after 6 hours, things tend to stabilize. And magically, if you get to hour 12 and the patient hasn't had any major trouble like ischemic valve from all this, they start getting better. Because myocardial edema starts going down and the heart starts working more efficiently. The vasoplegic response, or the capillary leak response, is sealed up so they're not requiring so much fluid, and things start getting better. So typically, the night shift will go home, the day shift will come on, and they'll think, well, I fixed this patient. And just because I got here, I know what they're doing. I don't know what they're doing. But that may be the case, but it's really not the case. What's the case is that 12 hours is hit, and suddenly things get better, so they get to turn all the drips down that you turned up all night. They don't understand why you need to use them. All right. So in the long haul, it gets more interesting. Those patients who've been in the intensive care unit, for 4 or 5 days on all these drips, and they're getting better, and your hemodynamics are kind of borderline. Let's say how you're going to mean arterial pressure is 65, cardiac index 2.2, and they're on all this stuff. But they're alert, they can urine, and it looked pretty good. You can say, now, how are we going to wean this? This is when you start thinking real physiologically. You say, okay, we're on levodopa, epinephrine, and milrinone. And this is what we got. What are we going to do? You say, okay, I don't want to give them fluid because now we need a diurese because their FiO2 requirements are 80% comfort. That's better than it was yesterday. This is somebody who you kind of just ride the storm out and you go very slowly. Or we don't do the NASCAR ICU care, which I keep talking about. This one is somebody who you take one of the vasopressors down just a little bit. Because if you take the vasopressor down, it's going to decrease peripheral vascular resistance, increase cardiac output. And as that happens, then you say, wait a minute, blood pressure is too low, but we got a lot of cardiac output. Let's take the milrinone down just a little bit. So we'll take that away, that peripheral vascular resistance will come back up, and you just balance in that. And you do it like one little step at a time. And the reason you have to do it one little step at a time, which I don't think we've ever really talked about, is these beta receptors and alpha receptors downregulate. Meaning that if someone comes out on epinephrine and they're on 0.2 and you plug them in the monitor and their blood pressure says 180 over 40 or whatever, you go, oh my God, blood pressure is too high. Let's turn the epinephrine off. Have you done that before? You have. That doesn't work too well. Because about how long after you turn it off did all hell break loose? That's right, 3 to 5 minutes. Why is that? The half-life of epinephrine, where'd you learn that? Yeah. The half-life of the catecholamines is 3 to 5 minutes. So if you look at the pharmacology behind it, it takes 5 half-lives to reach steady state and 5 half-lives for it to all go away. And half-life means half the effect of the drug is gone. So if you turn the epinephrine off, about 3 minutes later you're going to notice the difference, and about 10 minutes later you're going to be putting it back on. When you put it back on, the beta receptors have been downregulated, so it takes more to get where you were before, and that's why. So the best thing to do is to just go slow. When you make a change, a small change, you got to wait 3 to 5 minutes, which is 1 half-life, preferably about 3 half-lives before you make another change. I think that's probably good enough, really. Any questions about this or scenarios you want to go over about how to manipulate things?
I have a question.
Yeah.
It's not even really, it's just related to nitroglycerin, actually. I was curious yesterday, I took care of a patient who had an aortic root graft and valve, and I know that we wanted her blood pressure on the lower end, and she came out on nitro, and but what I guess what I don't understand is I know that nitro is a vasodilator, and if we're on pump, and I know that based on that we have an inflammatory response, so we do vasodilate. So why are we giving her nitro to keep the pressure down as opposed to something else?
All right. So what choice? Let's see what choices that we have to keep the pressure down.
Okay.
Okay. So the choices that we have, and we're talking about things you can give IV, and you can take away quickly. Because early post-op, what you don't want to do is give somebody something that's going to last for 12 hours. Because things may get worse during the next 6 hours, or they may get better during the next 6 hours. But if you gave them something you can't take away, then you're sitting here going, boy, I wish I wouldn't have done that.
Nowadays.
Yeah, what do I do? Yeah. So that's why if someone comes out and their heart rate's, 120, the blood pressure's 140, you're not going to slam them with some long-acting beta blocker. Because the next thing you know, their heart rate's going to be 60, they're pacer-dependent, and here we go. All right, so the choices you have for blood pressure control early after surgery would be nitroglycerin, nitride, which is mentioned only to be condemned. I don't have an opinion about that at all. Nicardipine. You can use something like esmolol. That's about it, really. You have IV vasopressin you can use and those kind of things, but that lasts too long. These drugs, you turn them on and turn them off, with the exception of this one, which is why I put it up here. Because I used to use this a lot, but I found that it's not a good drug to use in the CTICU. Because you all have not looked at the package insert on that particular drug. If you ever do, you'll realize that it doesn't act like those other drugs. That stuff has a half-life around 12 minutes. And so when you first turn it on, it's not going to act like, you're not getting a blood pressure response right away. And suddenly you can look up, well, the blood pressure is low. Then you're going to turn it off, and it's going to go boom. So, and usually it stays down for a while because it takes a while to go away. So I stopped using that routinely just because of that, because it's difficult to manage unless you really sit down and look at it and read it and say, oh, now I know how it works. I'm not going to react immediately to what I see. So you basically come down to these three drugs. Now, if you look at nitride, and the reason that I don't use it, besides the cyanide toxicity that can happen, it has to do with where we would use it. We'd use it in these thoracic aneurysms, and the thoracic aneurysms, in my mind, get broken down into two categories. The thoracoabdominals, where we want to keep the blood pressure up because we need to preserve blood flow to the spinal cord, which is a different breed of cat than what we're usually doing, acute dissections. Ascending aneurysms, where we want to keep the blood pressure controlled because we've got fresh suture lines, we're worried about bleeding and tribal tissue. So if you look, and I call it the DPDT, if you look at a usual arterial waveform, if I'm building a boom pump or a monitor, it kind of goes like this. Okay? But sometimes if you look closely, it doesn't go like that. It goes, all right? And sometimes it goes like that. Just boom, 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 up and down. If you think about that, that sweep is showing you the blood pressure change over time, right? So the blood pressure change over time in that slope is much steeper than that slope, the rise of the blood pressure. All right, here's the blood pressure, here's the blood vessel wall. And it doesn't strictly work this way, but we got this blood pressure coming on the inside of the blood pressure wall, weak systole, and banging on the wall from the inside. Little guy's got a hammer with every blood pressure. Now, if you think about it, the rate of rise of that means that the hammer's coming in there like this. The rate of rise of that, right? Yeah, so that's why. So that's why we use nitride, because nitride makes you, if you watch somebody on nitride, you really watch their arterial waveform next time someone makes the mistake and puts them on the drug. Don't mention it. Don't tell them they're doing the wrong thing. Just don't say. Dr. Skella said not to use that drug. That'll make them real happy if you do that. But look at the blood pressure waveform. It'll do this. It'll bam, and it's gone. If you put someone on a beta blocker, it'll do this. The waveform will change to this really slurred up slope. Right? So if you look at what we do for people with acute dissections, they get beta blocked. They get beta blocked because it's a slow rise in waveform. And the way I try to describe to people is like getting a hammer, putting on the nail and pushing on it, as opposed to coming down with a hammer and just banging the snot out of it to drive it in. So that's why I don't use nitride. Nitroglycerin actually works as a capacitance vessel dilator. Really, it dilates smooth muscle, and particularly on the venous side. So it actually decreases blood return to the heart at some level, and therefore it's very gentle in blood pressure control, and it goes away quickly. It does have the side effect of some peripheral vascular resistance, but that's by and large how it works. Okay.
And one more question.
Yeah.
So would it be more appropriate for her, if her pressure was still elevated, like based on your parameters, to continue with the nitroglycerin to help decrease her blood pressure as opposed to Cardi because
Yeah.
cardine is what was started.
Right, so
And
nicardine.
cardine is what I played with.
Right.
And finally got it to a level that I was like, oh, we're good.
Yeah, so nicardine, it's a great drug for this, but once again, it's a drug that's more difficult to use if you're not used to it. And really, next time, this is what I do when I come across a new drug, the pharmacist, I'll ask the pharmacist for the package insert. They look at me like I'm crazy. But really, if you look at the package insert, there's all sorts of interesting stuff in there. And just ask them for it. Or you can Google it, you gotta, just go to Hippocrates and look it up, but if you get that piece of paper, it's easy to have it. I remember that, and then you have put it in your pocket or something. I used to carry it around for nicardine meeting, so I understood it worked. And I used to actually, when we first started using the drug in the St. Joe's ICU, I would actually go up to the nurse looking at the patient with the package insert and go over with them, so they understood the medication. So it's a good medication because what it does, it's a calcium channel blocker, and it'll do this.